Welcome to Clinicals with FarmVic. Today I will be talking about wilderness medicine. In specific, introduction to bites, stings, and rashes in the wilderness. Bites, stings, and contact with plants in the wilderness can produce local and systemic reactions. Any bite or sting or exposure to plant irritant can cause an allergic reaction, including anaphylaxis. Some bites, stings, and rashes are associated with a risk of systemic envenomation, including those caused by spiders, snakes, marine stings, ticks, and toxic plants. Other causes of bites, stings, and rashes include insects, for example, bees, wasps, ants, mosquitoes, sandflies. Scorpions, centipedes, millipedes, caterpillars, and leeches. Heat rash. Contact dermatitis, for example, after contact with plant irritants. Infection, which can complicate any bite, sting, or plant irritation. Avoid antibiotics to treat local reactions to bites, stings, or plant injuries unless evidence of infection is present, for example, cellulitis. Prevention of bites, stings, and rashes in the wilderness. To prevent bites and stings, heat, and plant irritations, offer patients spending time in the wilderness education about appropriate clothing such as long-sleeve tops, hats, long trousers, long socks, for example, anti-leech socks, to minimize exposure to bites, stings, and plant irritants, light-colored clothing to make ticks more visible, breathable fabrics to reduce sweat condensation in skin folds. Topical repellent on the skin such as diethyl metatoluamide, DATE. For tick bite prevention, picaridin can also be used. Repellent can be impregnated in some clothing, including socks, for example, permethrin for tick prevention. Wound cleaning to reduce risk of secondary infection. Early rinsing is also important in limiting inflammation if contact with a known irritant plant has occurred. Ensure that patients with a history of allergy to bites, stings, or other irritants have a management plan and appropriate medications, including an adrenaline, epinephrine, autoinjector for those with a history of anaphylaxis. Also, management of specific bites, stings, and rashes in the wilderness. If an insect is trapped in a person's external ear canal, olive oil or vegetable oil can be used to kill the insect as first aid and to assist removal with an otoscope. In Australia, scorpions, centipedes, millipedes, and caterpillars are not known to cause serious systemic envenomation, although some can cause intense local symptoms, pain, swelling, and paresthesia. Anaphylaxis is not common. Ice and simple analgesia are usually sufficient to manage symptoms. Some patients report hot water alleviating pain in scorpion and centipede bites. If itch is present, antihistamines can be used. Caterpillars can leave irritant hairs attached to skin, which can be removed with tweezers or adhesive tape. Millipedes can release irritant fluids that cause inflammation and marked brownish-purple hyperpigmentation. The hyperpigmentation is not harmful, but can be mistaken for systemic conditions such as ischemia, trauma, meningococcemia, bacterial endocarditis, or cryoglobulinemia. Clean affected skin thoroughly with soap and water or alcohol. Pigmentation dissipates over weeks to months. Leech bites can result in palpable purpura with itch. If leech bite is suspected, look for an attached leech, particularly in the skin folds and scalp. Remove leeches manually. Applying salt, a salt solution or vinegar beforehand may help detachment. Apply pressure to the bite site if bleeding persists. Plant dermatitis generally presents as an asymmetric rash that may be linear or streaky. Ensure the area is washed well to remove residual irritant or allergen. Introduction to tick bite illness. Ticks are widespread in Australia. The scrub paralysis tick Ixodes holocyclis causes 95% of tick bites in Australia. It is found along the whole eastern seaboard, generally up to 30 kilometers inland, although it can occur in pockets up to 100 kilometers inland. Ticks can cause persistent local reactions, persistent arthropod reaction, systemic allergic effects, neurotoxic effects from venom, and transmission of rickettsial and coxiella infections. Presentation of tick bite and tick bite illnesses. Tick bites are painless and may only be noticed once the tick becomes engorged, which can take 2 or more days. They tend to be in moist or vascular areas, such as the scalp or flexures. Although tick bite is often asymptomatic, acute or short-term reactions such as anaphylaxis and local reactions can occur. Tick bite can also be associated with systemic conditions including tick paralysis, tick-borne infection, and mammalian meat allergy. Anaphylaxis can occur early but is rare. Ensure the patient has an adrenaline epinephrine autoinjector and an anaphylaxis management plan for future episodes and is aware of advice on prevention of bites. Local reactions and infections are common, but usually take some days to manifest. Patients should be warned that a prolonged local reaction, with or without infection, is common unless all of the tick, including the head, is removed. Removal of ticks. Removal of ticks can be complicated. Patients may attempt to remove a tick before presenting to a health professional. Patients should not attempt to remove ticks using tweezers or other tick removal gadgets, as this can cause the tick to release venom. For patients with a known allergy to tick bites, it is preferable that the tick is killed and removed in a medical facility that can manage anaphylaxis. People who are not allergic to tick bites can kill the tick in situ by freezing it with an ether-containing spray available from pharmacies, which should cause it to drop off the skin within 5 minutes. If the tick is largely embedded, permethrin cream can be dabbed onto the tick. Other chemicals should not be applied, for example methylated spirits, kerosene, oil, alcohol, matches, nail polish, because they are ineffective and cause the tick to embed further. If the tick remains attached, the person should seek urgent review by a health professional. Health professionals can use forceps with fine blunt points to remove ticks, preferably after they have been killed by freezing or with permethrin. Particular care must be taken to remove all of the tick and not to leave the head embedded, because retention can contribute to a prolonged local reaction lasting up to 10 days. Attachment is stronger the longer the tick has been present and feeding. Because tick mouthparts are barbed, they are highly likely to be retained unless a tick drops off after being killed or detaches naturally. The key is to place the points of the forceps as close to the skin as possible so that when the tick is pulled out, it remains intact. All these techniques may not remove mouthparts entirely. Removal of the tick using a punch biopsy can be considered to ensure the mouthparts do not remain in situ. Tick paralysis. Tick paralysis requires that the tick be attached for 4 to 5 days and is therefore rare. It takes a few days to manifest, presenting as an ascending paralysis, initially with leg weakness and an unsteady gait. In more severe envenoming, the weakness increases to involve the upper limbs, trunk, and neck muscles. Facial and bulbar muscles can also be affected, causing ptosis, extraocular muscular paralysis, dysarthria and stridor, and ultimately respiratory muscle paralysis. Tick paralysis is an important differential diagnosis of ataxia in children. It can present in less severe cases as a regional or cranial nerve palsy in adults, and may mimic facial nerve Bell palsy. Mild to moderate tick paralysis usually requires no intervention except observation and serial neurological examinations for 48 hours after tick removal. The paralysis may progress after the tick is removed. In severe poisoning, treatment consists of advanced life support with intubation and mechanical ventilation for respiratory failure. Antivenom for tick paralysis is no longer available. Mammalian meat allergy following tick bite. Mammalian meat allergy is a relatively recently recognized phenomenon in which tick venom causes sensitization to an allergen known as alpha-gal. The prevalence of mammalian meat allergy is uncertain. Symptoms often do not start for several months after a tick bite. They present as allergy of varying severity. anaphylaxis, angioedema, gut symptoms, generally 3 to 6 hours after ingesting meat, milk, or other products containing alpha-gal, egg gelatin-coated medication. Consider the possibility of mammalian meat allergy in patients presenting with allergy as a delayed presentation after tick bite, or in tick endemic areas, even if a history of tick bite is not known. If a mammalian meat allergy is suspected, referral to an immunologist is recommended. Management of confirmed mammalian meat allergy includes education of patients about avoidance of alpha-gal in mammalian meat and gelatin-containing foods, medicines, and blood substitutes. If this lesson helped you, don't forget to hit that subscribe button. Please share this video to someone you never know who might need the right information to ace their exams or become more clinically sound. Let's grow together, learn, revise, and succeed.